So, if you found out your immune system was actively attacking your skin, you would probably just assume the core problem was, well, in your skin.
Right, which makes total sense.
Yeah, but what if that localized rash was actually like a flashing warning light that your thyroid was about to fail?
It's a terrifying thought, honestly.
It really is. So today we are doing a deep dive into lichen sclerosus, or LS, and we're pulling from some pretty dense medical guidelines,
Yeah.
like the British Association of Dermatologists, the Euroguiderm protocols, and several recent peer-reviewed meta-analyses.
Oh, yeah, there's a lot of data to unpack here.
Definitely. And our main mission today is to answer one really big overarching question for you. Does a diagnosis of lichen sclerosus indicate that your entire immune system is just fundamentally broken?
Yeah, and that is literally the first question most patients ask when they start reading the literature, like, is my whole body failing? And the medical consensus has actually shifted dramatically on this over the last decade or so. We've really moved away from treating this as just, an isolated dermatological annoyance.
Like a random rash.
Exactly. We're now understanding it as a window into systemic immune function. When we look at the data, the boundaries we like to draw between like a surface level skin condition and internal biological mechanics, they just completely dissolve.
Wow. So we know LS features this Th1 dominant inflammatory profile, right?
Mm-hmm.
Where these errant T cells infiltrate the dermis and cause the signature thinning, the white patches, the structural fusion.
Yes, that's the classic presentation.
But if we want to figure out whether the whole immune system is broken, I feel like we have to start at the scene of the crime.
Yeah.
So what are those T cells actually doing when they get into the deep layers of the skin? Are they like a localized SWAT team hitting the wrong house?
That's a really good way to put it because the T cells aren't actually eating the skin cells directly, if that makes sense.
Well, they aren't.
No, they are infiltrating the dermis and releasing just massive amounts of inflammatory cytokines, specifically interferon gamma and interleukin-1.
Okay, so what do those do?
Well, these chemical signals essentially hack the local tissue. They upregulate these enzymes called matrix metalloproteinases.
Wait, so they are basically commanding the local environment to destroy itself.
That is exactly the biological mechanism, yeah. Those upregulated enzymes aggressively break down your collagen and elastin. So the T cells are like tricking the skin's own structural maintenance crew into demolishing the scaffolding.
Wow, so that's why you get that severe architectural loss in the tissue.
Precisely.
Yeah.
It's an inside job, biochemically speaking.
But wait, if we were trying to determine if this is a systemic problem, I really have to point out something glaring in these sources.
Go for it.
So several of the meta-analyses note that researchers have isolated specific autoantibodies in the blood of LS patients.
Yes, the ECM1 antibodies.
Right. Antibodies targeting extracellular matrix protein 1 and also the BP180 antigen. If my blood is full of circulating antibodies actively hunting down my own skin proteins all over my body, I mean, how can we possibly call this a localized problem? That sounds like a textbook systemic autoimmune disease.
I mean, you've just hit on the central debate in the dermatology field right now. It's this huge balancing act of mechanism versus clinical manifestation.
Because it looks systemic on paper.
Exactly. Yes, the condition absolutely shares biological mechanisms with classic systemic autoimmune diseases like lupus or rheumatoid arthritis. However, the actual damage in LS is overwhelmingly localized to the vulvar skin in women or the foreskin and glands in men.
But doesn't it show up elsewhere sometimes?
It does, yeah. We see extragenital LS like on the trunk or arms in about 15 to 20% of cases. But, even then, it's highly regionalized. It's not everywhere.
Okay, but if it's regionalized, what are those ECM1 antibodies doing circulating throughout the entire bloodstream? Like, why are they there?
So a growing faction of researchers suspects those autoantibodies might actually just be an epiphenomenon.
An epiphenomenon, meaning like they are a byproduct of the destruction, not the actual instigator.
You got it. The prevailing theory right now is that the initial T-cell attack causes this severe, localized damage to the basement membrane of the skin.
Right.
And this destruction essentially releases internal skin proteins like ECM1 into the bloodstream, somewhere they really don't normally belong.
Oh, I see. So the broader immune system spots them and freaks out.
Exactly. The immune system detects this circulating cellular debris, registers it as foreign, and generates antibodies against it. So the antibodies are actually a reaction to the localized tissue damage.
It's like a local fire that generates systemic smoke.
Yes. That's a perfect analogy. The fire itself remains largely contained to that one specific neighborhood, but the smoke goes everywhere.
Okay, but if these antibodies are just systemic smoke, Why do the Euroguiderm guidelines practically beat doctors over the head with the need to look for other diseases throughout the body? Like, why is a doctor suddenly testing a patient's thyroid just because of a localized skin issue?
Because of the staggering demographic overlap. We call it the cluster effect.
The cluster effect. Okay, lay the numbers on me.
When we examine the broad clinical data, roughly 20 to 35% of women diagnosed with vulvar lichen sclerosus have at least one other recognized autoimmune condition.
Wait, really? Over a third of patients in some cohorts.
Yeah, it's massive.
That completely removes coincidence from the equation.
Yeah.
I mean, what else is clustering with it?
The dominant comorbid condition by far is autoimmune thyroid disease. So we're talking Hashimoto's thyroiditis or Graves' disease. And the gender divergence here is actually fascinating.
How so?
The sources highlight that thyroid disorders are associated with 18.9% of female LS patients, compared to just 5.1% of male patients.
Wow. So nearly 1 in 5 women with LS are also dealing with their immune system attacking their thyroid gland.
Exactly. And the cluster doesn't even stop at the thyroid. The medical guidelines mandate vigilance for a bunch of things: vitiligo, alopecia areata, pernicious anemia, and type 1 diabetes.
Okay, we need to understand the direction of the causality here, because this is crucial for anyone listening. If I have lichen sclerosus, does the chronic inflammation eventually travel and cause my thyroid to fail? Or does a failing thyroid disrupt my hormones enough to cause the LS?
It's actually neither.
Oh, really?
Yeah, it's not a domino effect like that. The literature shows they share overlapping immune regulation pathways. It's a shared baseline dysregulation.
Meaning the system is just inherently glitchy from the start.
Right. Your immune tolerance, which is that complex biological mechanism that basically forces your white blood cells to ignore your own healthy tissue, has a foundational glitch.
So having LS means your internal checkpoints are already compromised.
Exactly. You are statistically highly prone to developing a second condition on the autoimmune spectrum because that foundational vulnerability is systemic, even if the LS itself is localized.
Okay, so if genetics essentially lay down the dry tinder for this vulnerability, what is actually striking the match? Let's get into the pathophysiology here.
Yeah, let's do it. So the tinder is laid down through very specific hereditary pathways. About 10 to 12% of LS patients actually have a first-degree relative with the condition.
Oh, so there's a strong family link.
Definitely. And when we look at the genetics, we find specific human leukocyte antigen variants, namely HLA-DQ7 and HLA-DR12.
Right, the HLA genes. We can think of those as like the immune system's ID scanners, right?
Yeah.
They determine how your body presents proteins to your immune cells to say, hey, this is friendly tissue, do not attack.
That's spot on. So when you inherit variants like HLA-DQ7, your ID scanners are inherently faulty.
They're misreading the IDs.
Right. They are much more likely to present a normal self-protein in a way that makes it look like a pathogen. But the tinder gets even drier when we look at the epigenetics.
Oh boy, what's happening there?
Specifically, the overexpression of microRNA 155.
Okay, so microRNAs regulate gene expression. They bind to messenger RNA to block protein production. So what exactly is microRNA 155 blocking in these LS patients?
It is actively suppressing the function of regulatory T cells, or TREGs.
And TREGs are the peacekeepers, right?
Exactly. They are the brake pedal of the immune system. They're designed to shut down an attack once a threat is neutralized or, if friendly fire begins. But the overexpression of microRNA 155 essentially silences the genes that allow those TREGs to function.
Okay, so you have faulty ID scanners marking healthy tissue as a threat, and your biological brake pedal has been completely removed.
Yeah, it's a perfect storm.
The tinder is bone dry.
Yeah.
But, not everyone with HLA-DQ7 actually gets LS. So what strikes the match? What triggers it?
Well, the primary physiological match in females is a low estrogen state.
Oh, hormones.
Yeah. This perfectly explains the stark bimodal age distribution we see in the incidence rates. The peaks are in prepubescent girls and postmenopausal women.
That makes so much sense. But how does the lack of estrogen actually trigger an immune response?
Estrogen plays a really critical role in maintaining mucosal thickness, elasticity, and local barrier function. It regulates the production of things like hyaluronic acid and collagen.
So without it, the skin gets fragile.
Exactly. In a low estrogen environment, the tissue architecture thins out and becomes highly susceptible to micro tears.
Oh, and those tears expose things.
Right. They expose deeper tissue proteins to the immune system. So in a genetically primed individual individual who doesn't have functioning tregs, that tiny bit of exposure is enough to initiate the whole Th1 dominant cascade.
Which perfectly sets up the next major trigger mentioned in the sources, right? The Koebner phenomenon.
Yes, mechanotransduction at its most frustrating.
Yeah, it's essentially physical trauma activating an autoimmune response in previously healthy skin.
Exactly. The physical tension from chronic scratching, overly tight clothing, rubbing, or even surgical scarring, it isn't just mechanical wear and tear.
It's sending signals.
Right. The stressed skin cells, the keratinocytes, release distress cytokines. Now, in a robust immune system, these signals just recruit cells to repair the tissue.
But in an LS patient,
In someone genetically predisposed to LS, the faulty immune system completely misinterprets those distress signals. Instead of initiating a healing protocol, it launches an aggressive autoimmune attack on that specific friction site.
that is so unfair. The body tries to heal a friction burn and accidentally permanently alters its own tissue structure.
It really is.
Wow.
And the guidelines actually note that severe trauma, including sexual abuse in children, can act as this trigger too.
Wow. It just demonstrates the profound biochemical link between physical trauma, tissue stress, and immune activation.
Absolutely.
And the Euroguiderm guidelines were also very explicit about a chemical trigger, particularly relevant to male patients, right? The trapping of urine.
Yes. In uncircumcised males, urine trapped under the foreskin acts as a chronic chemical irritant. The urea and ammonia actively degrade the stratum corneum, which is the outermost layer of the skin.
So it's basically slow chemical burn.
Exactly. And this constant burn forces the keratinocytes into a chronic state of cytokine release, which pulls the exact same immunological trigger as physical friction.
And the data on this is wild. Circumcision at birth almost entirely eliminates the risk of male lichen sclerosus.
It does. It permanently alters the local microenvironment so that chemical irritation just cannot occur in the same way.
Okay, so let's summarize where we are. We have a localized immune fire, destroying collagen, driven by faulty genetics and a lack of immune brakes. And it's ignited by hormones, friction, or chemical irritation.
That's the mechanism in a nutshell.
Understanding that completely changes the playbook for how a listener should handle their diagnosis.
Yeah.
You can't just accept a prescription for skin cream without also setting up a systemic smoke detector.
Right, you really must do both. But I want to stress the clinical priority is extinguishing the local fire first. The gold standard for treating LS remains the long-term proactive use of ultra-potent topical corticosteroids.
Like clobetasol propionate. But, the patient support literature frequently highlights this widespread fear of using strong steroids on delicate tissue. Patients are terrified it will cause further skin thinning.
And it is a completely logical fear. We're taught steroids thin the skin, but it's clinically backward in the context of LS.
No, so
Because active lichen sclerosus causes exponentially more architectural damage than a properly applied ultrapotent steroid ever could.
because the steroid stops the attack.
Yes. The steroid molecule diffuses into the cells, binds to glucocorticoid receptors, and directly alters gene transcription to basically shut off the cytokine fire hose. It forces the T cells to retreat.
So it literally stops the destruction of the collagen and prevents the severe scarring and fusion.
Exactly. But the guidelines stress another incredibly critical reason for absolute compliance with these steroids, and it actually has to do with oncology.
Right. Cancer. Untreated chronic LS carries an estimated 4 to 5% lifetime risk of developing squamous cell carcinoma in the affected area. So let's explain the mechanism there. How does an autoimmune condition turn into skin cancer?
It really comes down to cellular exhaust.
Cellular exhaust.
Yeah. When immune cells constantly bombard the tissue over years and years, they release reactive oxygen species. This creates immense oxidative stress in the local environment.
Like chemical chaos.
Right. These unstable oxygen molecules literally rip electrons away from the DNA of the surrounding skin cells.
Oh, wow.
And because the skin is desperately trying to heal itself and turning over rapidly, those DNA mutations get replicated. So the chronic inflammation basically creates the perfect chaotic environment for a cancerous mutation to take hold and thrive.
That is mind-blowing. So the steroid cream isn't just a symptom manager for the itching. It is actively protecting the skin's DNA from oxidative stress and preventing malignant transformation.
That is exactly what it's doing.
Okay, so the local fire is contained with the steroid. How do we build that systemic smoke detector? Because of those high comorbidity rates we discussed earlier, having LS means you have to actively demand systemic screenings from your doctor.
You absolutely do. When you consult your doctor for LS, you should be requesting specific blood panels to monitor for those common cluster diseases.
Starting with the thyroid.
Foremost is a comprehensive thyroid panel, yes. You need the TSH, the free T3 and T4, and critically, the thyroid antibodies.
Right, to check for subclinical Hashimoto's before the gland completely fails.
Exactly.
Catch it early.
The guidelines also put a pretty surprising emphasis on nutritional absorption metrics. I mean, B12 is obvious because of the pernicious anemia link, but the guidelines specifically highlighted ferritin.
Yes, 20% of women with vulvar dermatitis actually have iron deficiency anemia.
20%. Why is iron so important here?
Iron is a critical, often overlooked cofactor for cellular respiration and mucosal integrity. When your ferritin stores are depleted, your mucosal barrier is structurally compromised on a cellular level.
Oh, so it goes back to the microtears.
Exactly. It makes the tissue far more susceptible to the microtears and those inflammatory loops we discussed earlier.
So fixing the iron might help the skin. Yes, correcting the systemic iron deficiency can sometimes dramatically improve the local vulvar symptoms just by reinforcing the structural integrity of the skin. You cannot treat the localized dermal tissue while ignoring the systemic blood chemistry that feeds it.
It's all connected.
Yeah.
So circling back to our core mission for this deep dive, does a diagnosis of lichen sclerosus indicate that your whole immune system is fundamentally broken?
The answer is a nuanced no.
Nuanced. I like that.
hmm
Your immune system isn't in a state of total failure, but it possesses a baseline dysregulation. The ID scanners are glitchy, and the regulatory brakes are loose.
Right. It is a highly localized manifestation of a systemic vulnerability. The destruction is regional, but the susceptibility is global.
That's a great way to summarize it. This is why a diagnosis should serve as a permanent biological heads-up.
Absolutely.
It's an opportunity to get ahead of the clustering effect. You treat the skin with absolute diligence to prevent the architectural damage and the oxidative stress, but you keep a constant eye on the thyroid, the B12, and the iron.
And, as we look at where the science is actually heading, there is a fascinating thread in the European guidelines that points toward the next major frontier in understanding this whole systemic local relationship.
Oh, what is it?
They note the emerging role of dysbiosis, which is an imbalance in the microbiome.
Okay, that's interesting. We usually think of the microbiome in terms of digestion, right?
hmm
But the bacteria living in our gut and on our skin are actually in constant communication with our immune cells.
They are. They are actively training the immune system. Commensal bacteria produce metabolites, like short-chain fatty acids, that actually stabilize and support those regulatory T cells we talked about earlier.
The brake pedals.
Right. If a patient's microbiome is in a state of dysbiosis, they aren't producing the metabolites needed to keep those immune brakes functioning properly.
Wow. So if the bacteria are basically sending the wrong training manuals to the immune cells, that entirely reframes how we might treat this in the future.
It really asks a profound question. Will the future of treating immune-mediated conditions like LS involve aggressively fixing the gut and local skin flora to restore immune tolerance?
Rather than relying solely on suppressing the host's immune response with steroids.
Exactly. It's a really compelling avenue of research that directly ties the systemic environment to the localized symptom.
It really is. So if you were looking at that flashing warning light on your dashboard, use it to look deeper under the hood. Keep investigating the mechanisms, keep advocating for those systemic screenings, and we'll catch you on the next deep dive.